America is a nation of paradoxes, touting the most advanced medical technology and innovations in the world, yet struggling to provide affordable healthcare to a significant portion of its population. Despite spending more on healthcare per capita than any other country, the United States consistently ranks poorly in overall health outcomes, life expectancy, and access. At the heart of this paradox lies one critical question: why is healthcare so expensive in America? This essay explores the multi-layered reasons behind the high cost of healthcare in the U.S., from the lack of price regulation, profit-driven corporate structures, administrative bloat, pharmaceutical pricing, and employer-based insurance to lobbying and policy failures. The American healthcare system is not just expensive, it's complex, fragmented, and riddled with inefficiencies that burden patients and providers alike. Understanding the root causes is essential not just for policymakers, but for every American who has ever struggled with a medical bill or gone without care due to cost. A historical glance at the American healthcare system. To understand why healthcare is so expensive in the U.S., one must first look back at how the system evolved. Unlike other developed nations that moved toward centralized, government-run or heavily regulated healthcare systems after World War II, the United States took a different path. Healthcare in America became commodified, a product to be sold, bought, and profited from. In the mid-20th century, employer-based insurance took root as a way to attract workers without violating wage controls. Over time, this system became the norm, tethering insurance coverage to employment. When Medicare and Medicaid were introduced in 1965, they were intended to cover the elderly and low-income populations. However, they added another layer of complexity to an already fragmented system. No comprehensive, universal healthcare model was ever adopted, leaving the door wide open for a market-based approach to dominate. By the 1980s and 1990s, the rise of for-profit hospitals, insurance conglomerates, and pharmaceutical giants began to define the American healthcare landscape. The focus shifted from patient care to shareholder profit. Unlike in Europe or Canada, where the government plays a central role in controlling costs, American policy continued to favor free market principles. Lack of price regulation and transparency. One of the core reasons for America's high healthcare costs is the lack of price regulation and transparency. In most developed nations, governments set or negotiate prices for healthcare services, procedures, and medications. In contrast, the U.S. allows prices to be set by a largely unregulated market. Hospitals can charge different prices for the same procedure, depending on the patient's insurance company, or lack thereof. A simple MRI scan might cost $300 in one facility and $3,000 in another, even within the same city. Unlike shopping for a car or a phone, patients often have no idea what the cost of a medical procedure will be until after they receive the bill. Additionally, insurers negotiate different rates with hospitals and providers, which adds layers of secrecy and inconsistency. This lack of standardization fuels inefficiency and allows healthcare providers to overcharge without accountability. While other countries benefit from economies of scale and centralized negotiation, the U.S. system is riddled with middlemen and opaque pricing structures. Administrative costs and bureaucracy. Administrative expenses account for nearly 25 to 30% of total healthcare spending in the U.S., far higher than in any other country. These costs stem from the need to manage complex billing systems, insurance claims, pre-authorizations, coding, compliance, and endless paperwork. Because there are thousands of private insurance companies, each with its own rules, networks, and reimbursement procedures, hospitals must employ large administrative teams to navigate the chaos. For every doctor, there are multiple support staff members doing administrative work. In contrast, countries with single-payer systems, like Canada and the UK, spend far less on administration because billing is simplified, and reimbursement is standardized. The U.S. healthcare bureaucracy is so vast and convoluted that even doctors report burnout from having to spend more time on paperwork than on patient care. The role of private insurance. The private insurance industry plays a pivotal role in driving up healthcare costs. In a typical year, major insurance companies like United Health Group, Anthem, and Aetna report billions in profits, money that comes from premiums paid by employers and individuals. Insurance companies operate on a profit-driven model, meaning their priority is often to maximize shareholder value, not patient outcomes. High executive salaries, marketing costs, and administrative overhead all contribute to the bloated cost of healthcare. Moreover, the insurance model incentivizes inefficiency. Providers are often reimbursed on a fee-for-service basis, which means they get paid for every test, procedure, and visit, whether or not they are necessary. This leads to overtreatment and overutilization of services, driving up costs with little improvement in outcomes. The high price of prescription drugs. The cost of prescription drugs in America is another major contributor to overall healthcare expenses. Americans pay 2 to 3 times more for medications than people in other developed countries. There are several reasons for this. No government negotiation. Unlike in other nations where governments negotiate directly with pharmaceutical companies, the US has long prohibited Medicare from negotiating drug prices. Patent protections and exclusivity. Pharmaceutical companies extend patent life through slight reformulations or evergreening, delaying the entry of cheaper generics. Direct-to-consumer advertising. The US and New Zealand are the only countries that allow pharmaceutical advertising on television, inflating demand for branded, and often unnecessary, drugs. Lack of price controls. Drug makers can set prices at whatever the market will bear. Take insulin, for instance, a drug invented a century ago that still costs hundreds of dollars per vial in the US while costing a fraction elsewhere. The consequences are severe. Patients ration medication, skip doses, or forego life-saving treatment altogether. Hospital monopolies and market consolidation. In recent decades, the American healthcare landscape has seen a wave of hospital mergers and acquisitions, resulting in powerful regional monopolies. Large hospital systems can now dictate prices because they dominate entire geographic areas with little to no competition. These monopolies leverage their power to negotiate higher reimbursements from insurers and raise prices for patients. A lack of competition leads to price inflation, reduced access, and, paradoxically, lower quality of care. In many cities, a single hospital chain might own most of the hospitals and outpatient centers, making it nearly impossible for patients to shop around for affordable care. Furthermore, these systems often charge high facility fees on top of standard care charges, further increasing costs without improving patient outcomes. Medical malpractice and defensive medicine. Another factor contributing to America's expensive healthcare system is the fear of litigation. The US is known for its litigious culture, and doctors often practice defensive medicine, ordering extra tests, procedures, or consultations to protect themselves from lawsuits, rather than because they are medically necessary. While malpractice insurance itself is not a dominant portion of overall spending, the indirect cost of defensive medicine is substantial. A 2010 study estimated the cost of defensive medicine at over $45 billion annually. Though some argue this number is exaggerated, even conservative estimates acknowledge it as a non-trivial contributor. At the root of the issue is a legal system that encourages excessive caution, inefficiency, and sometimes redundant care, rather than prioritizing value and necessity. Medical education and physician compensation. Becoming a doctor in America is expensive. Medical school graduates often leave school with debt exceeding $200,000. These financial burdens influence their career choices. Many gravitate toward high-paying specialties over primary care to pay off loans faster. In addition, American doctors are among the highest paid in the world, especially in specialized fields like orthopedic surgery, radiology, or cardiology. While high compensation might attract talent, it also contributes significantly to the cost of care. Moreover, the high cost of training reduces the number of new physicians entering the workforce, contributing to shortages that further drive up costs. Countries with public funding for medical education are better positioned to produce enough doctors while keeping care affordable. Technology and innovation at a cost. America leads the world in medical innovation, robotic surgeries, gene therapies, cutting-edge diagnostics, and advanced treatments for rare diseases. However, these advancements come at a steep price. In the US, technology adoption is often driven by financial incentives rather than medical necessity. Providers invest in expensive equipment and then feel compelled to use it frequently to justify the cost, even when cheaper alternatives exist. Unlike other countries that assess cost-effectiveness before adopting new technology, the US lacks a centralized body to evaluate whether new treatments offer value for money. This leads to unnecessary procedures, redundant tests, and inflated billing. The impact of lobbying and political influence. Healthcare is one of the most heavily lobbied sectors in Washington, with pharmaceutical companies, hospital associations, and insurance conglomerates spending billions annually to influence policy. This lobbying power has successfully blocked efforts to regulate prices, implement single-payer systems, or allow Medicare to negotiate drug prices. The Affordable Care Act, ACA, while a step forward in expanding coverage, was heavily influenced by industry players and failed to address cost control aggressively. Political contributions ensure that healthcare remains a lucrative industry with minimal regulation, perpetuating high costs and stalling meaningful reform. In short, the profit motive embedded in American politics sustains a healthcare system built for business rather than for patients. The burden on patients and families. For everyday Americans, the consequences of this broken system are devastating. A trip to the ER can result in a 5-figure bill. Families go bankrupt due to medical expenses. Even insured patients struggle with high deductibles, co-payments, and surprise bills. The stress of navigating insurance networks, obtaining authorizations, and dealing with billing errors only compounds the emotional and financial toll. 1 in 4 Americans report skipping necessary care due to cost. Many delay treatments or avoid follow-ups because they simply can't afford them. Despite spending nearly 18% of GDP on healthcare, outcomes remain poor. Maternal mortality rates, infant mortality, and life expectancy in the US lag behind those of countries that spend far less per capita. Comparing global models. Globally, other developed nations have found ways to provide universal, affordable care. In Canada, a single-payer system negotiates prices and eliminates most private insurance. In Germany, a multi-payer model involves both public and private insurance but mandates non-profit structures and price regulations. In the UK, the National Health Service provides publicly funded care directly. These models differ in approach but share common elements: universal coverage, cost regulation, administrative simplicity, and patient-centered values. They show that high-quality care doesn't have to be expensive, it simply needs to be organized efficiently. Employer-based insurance, a flawed foundation. The backbone of the American insurance system is employment-based coverage. Over 150 million Americans rely on health insurance provided by their employers. While this may seem like a convenient arrangement, it is one of the most deeply flawed foundations of the healthcare system. During World War II, wage controls prevented employers from raising salaries, so they began offering health insurance as a benefit. What started as a workaround became the status quo. Today, the system is riddled with problems: job lock. Workers are often reluctant to change jobs or start businesses because they fear losing their health insurance. Coverage gaps. When employees are laid off or switch jobs, they may face lapses in coverage or need to pay exorbitant COBRA premiums. Inefficiency. Companies must manage their own plans, leading to duplicated administrative systems. Inequity. Part-time and gig economy workers often get no coverage, and small businesses struggle to afford plans for employees. This system also leaves retirees, the unemployed, and caregivers particularly vulnerable. In contrast, countries with universal systems ensure that life events do not determine access to healthcare. Rural healthcare disparities. The high cost of healthcare in America is not only a financial issue, it's also deeply geographic. Rural Americans face some of the greatest healthcare disparities. Over 100 rural hospitals have closed in the last decade, with more at risk, primarily due to low revenue and high administrative costs. In rural communities, patients often drive hours for basic care. There are fewer specialists. Emergency services may be inadequate or non-existent. Lack of broadband internet limits telemedicine access. While urban centers may be oversaturated with high-cost, state-of-the-art medical institutions, rural hospitals struggle to stay open. The pricing structure and insurance reimbursement models often penalize low-volume, rural providers, which forces closures and worsens health outcomes. Mental health, the forgotten crisis. Mental health care in the United States is both inadequate and expensive. Despite growing awareness, the system is severely underfunded, and access remains limited due to provider shortages and high out-of-pocket costs. Key problems include insurance gaps. Many plans offer limited mental health benefits, despite the Mental Health Parity Act. Shortage of professionals, especially in rural areas. Psychiatrists and therapists are in short supply. High copays. Patients often pay out of pocket for therapy sessions, which can exceed $150 per visit. Stigma. Cultural resistance and lack of education delay care, worsening conditions and raising costs later. Mental health crises also intersect with the criminal justice system and homelessness, placing additional burdens on society. Treating mental illness early and effectively is both humane and cost-effective, but the system is not designed to deliver that. Long-term care and aging populations. As the American population ages, the cost of long-term care is becoming a looming crisis. Medicare does not cover long-term care, leaving many elderly Americans to deplete their life savings or rely on Medicaid. Key cost drivers include nursing home care averaging over $100,000 per year in some states. In-home care that remains out of reach for many. Assisted living facilities with high monthly fees. Families often bear the emotional and financial burden, and disparities arise based on income and race. With baby boomers aging, the demand will only grow, and the system is not prepared. In contrast, other countries have national long-term care insurance or publicly funded systems to ease this burden. The role of technology, promise, and pitfall. Medical technology is a double-edged sword. On one hand, it provides miraculous capabilities, minimally invasive surgeries, robotic-assisted procedures, genomic testing. On the other hand, it is a significant cost multiplier. Technology drives cost because it is often overused or applied in marginal cases. There's little evaluation of cost-effectiveness. Hospitals charge exorbitantly for high-tech equipment usage. The US lacks centralized evaluation agencies like the UK's NICE. Even electronic health records, EHRs, designed to reduce paperwork, have become expensive, proprietary systems that are difficult to use and costly to maintain. The full potential of digital transformation in healthcare remains untapped due to fragmentation and profit motives. Waste and overutilization. Studies suggest that up to 25% of US healthcare spending is wasted. The waste comes in many forms: unnecessary procedures and redundant tests. Failure to coordinate care, leading to duplication. Excessive pricing for standard treatments. Fraud and abuse in billing. This waste is not just a financial issue, it also leads to patient harm. For instance, unnecessary surgeries or prolonged hospital stays increase the risk of infection and complications. A more integrated and preventative approach would reduce costs and improve outcomes. Health inequities and structural racism. The cost of healthcare disproportionately affects communities of color, low-income groups, immigrants, and the uninsured. Black and Latino Americans are more likely to be uninsured and suffer from chronic conditions like diabetes, hypertension, and asthma due to social determinants of health. Inequities manifest in higher maternal mortality among Black women, poorer access to specialty care in minority communities, delayed diagnoses due to economic and language barriers. These disparities are not just moral failures, they are economic drains. Untreated chronic illness leads to higher costs down the line, reinforcing a vicious cycle. A truly cost-effective healthcare system must address systemic inequities. International lessons and what the US can learn. From Canada's single-payer model to France's hybrid approach and Japan's strict price controls, other countries offer blueprints that America could learn from. Here are key takeaways. Universal coverage reduces administrative waste. With everyone in the same system, processes are streamlined. Government price negotiation lowers drug costs. Allowing Medicare to negotiate prices could save billions. Focus on primary care improves outcomes. A stronger emphasis on prevention keeps costs down in the long run. Non-profit health systems control costs better. Without the pressure to produce profit, costs remain reasonable. The challenge is not a lack of models, it's the political will to adopt and adapt them. The human cost, stories behind the statistics. Behind every statistic lies a real story. A single mother in Texas who skips insulin because she can't afford $400 per vial. A teacher in Pennsylvania who delays a cancer diagnosis because her deductible is too high. A retiree in Florida who files for bankruptcy due to a heart surgery bill of $150,000. These are not anomalies, they are features of the system. The American healthcare system is filled with stories of avoidable suffering, moral injury, and financial devastation. Real reform must start with listening to these voices and designing policy that puts people, not profits, at the center. Steps toward reform. What can be done? Addressing America's healthcare costs requires a multi-pronged approach. Universal coverage. Expand access through public options or Medicare for all. Price transparency. Mandate disclosure of costs for procedures, medications, and services. Administrative simplification. Streamline billing and coding systems. Drug price regulation. Empower Medicare to negotiate and introduce price caps. Value-based care. Shift from fee-for-service to outcome-based reimbursement. Mental health investment. Expand access and funding for mental health services. Health equity measures address disparities through targeted interventions and inclusive policy. Public long-term care options ensure aging populations are protected without impoverishing families. These are not radical ideas, they are practices that work in other parts of the world. So, the American healthcare system stands as a paradox. It is the most expensive in the world, yet it fails to deliver equitable, efficient, or consistently high-quality care to its population. The question of why healthcare is so expensive in America does not have a simple answer, because the problem is not simple. It is deeply rooted in the architecture of the system itself, which has evolved under the influence of market-driven principles, political lobbying, fragmented infrastructure, and an absence of universal coverage. As explored in this essay, a wide range of factors contribute to the exorbitant costs Americans face. These include inflated prices for services and drugs, an overwhelming amount of administrative waste, the dominance of private insurers, a lack of pricing transparency, and excessive use of expensive technologies. Compounding these issues are structural inefficiencies, disparities in access, and socioeconomic inequities that disproportionately burden rural communities, minorities, and lower-income families. At the same time, the system fails to deliver value for the money spent. Americans do not enjoy better health outcomes, longer life expectancy, or greater patient satisfaction than citizens of other developed nations. In fact, they often receive worse outcomes despite paying far more. The system's incentives are misaligned, rewarding volume over value, procedure over prevention, and corporate profits over public health. What is often lost in discussions of cost is the profound human cost: the single mother who skips cancer screenings because her insurance has a high deductible, the elderly man forced to spend his life savings on long-term care, the young adult with bipolar disorder unable to afford therapy or medication. These are not isolated cases, they are emblematic of a broken system that places financial barriers between people and the care they need to survive. This crisis is not just about economics or policy. It is about values. It forces us to ask, what kind of society do we want to be? One where access to life-saving care depends on your job, zip code, or bank account? Or one where healthcare is treated as a basic human right, accessible to all regardless of income or status? While there is no single reform that will fix everything overnight, there are meaningful steps that can be taken: implementing universal or expanded public coverage, regulating drug prices, shifting toward preventative and value-based care, investing in mental health and rural health infrastructure, and simplifying the bloated administrative system. These changes, while challenging, are both morally necessary and economically sensible. Other nations have shown that it is possible to provide high-quality healthcare for less money, and with far less suffering. The United States has the resources, the technology, and the talent to do the same. What it needs now is the political will, public pressure, and a collective reimagining of what healthcare should be. Ultimately, the debate over healthcare costs is a debate over priorities. As long as profit is prioritized over people, costs will remain high and outcomes subpar. But if the nation chooses to center compassion, justice, and equity, it can build a healthcare system that truly serves everyone, not just the wealthy, not just the insured, but every American. The path to a better system is clear. The only question is whether we will take it.